the great Radcliffe, one of my best friends, not only in ophthalmology, but in the world. And we're excited to you. We're going a little bit unplugged today. What we're going to do is go through a number of the modern glaucoma surgeries. We don't have slides that have any words. Those are going to come from us. We've got a couple overarching goals. One is to just make you aware visually of the numerous different glaucoma procedures that are out there. I think that's important as you educate your patients before referring them to a glaucoma specialist. Talk a little bit about what the techniques are, which patients are good candidates for which ones, which aren't, and then talk about the postoperative care and the nuances between the different kind of surgical procedures and what we're kind of hoping to expect in terms of timeline and outcomes. And I'm just excited to be here with you and really excited to be here with my good friend.
Thank you, John. It's great to be here. And I think, you and I will have a conversation, but it's also, it's interesting that as I manage glaucoma with all my friends and optometrists, how we're having a conversation too. And, they're educating me on what my patients look like, either coming in or out of a surgery. And I think the decision-making process is becoming much more collaborative. And that's why it's kind of exciting to share this side of it, because a lot of folks are already seeing one side of it. And so now we can kind of bring as much of that together as possible and into a nice synthesis of all the different options.
Let's dive in.
Yeah, in we go. And in you go, because I think our first video here is you performing a Durysta procedure.
Sure.
So you could either tell me about this patient or how you come to make this decision for this type of treatment.
Yeah, so, Durysta, as a reminder, it's the first glaucoma drug that is a drug delivery device. It's a little bioerodible pellet that goes into the anterior chamber usually, but I think that you may show one where it goes somewhere different. And it provides it, kind of at least 4 months worth of IOP lowering. One of the restrictions on it is that it's currently labeled for going in the eye only one time. So repeat use is an off-label indication. Now that doesn't mean we can't use it. Remember things like, Vigamox for cataract surgery are off use. So, I get preachy, and I usually don't get preachy this early in a talk, but as doctors, what we're responsible to is the oath that we took to patients. And so we have all of these tools, whether they're off-label or on-label, whether they're covered by insurance or not. Our first charge is to try and do what we believe is best for patients and work collaboratively with these patients. Now, what patients do I think work well for Durysta in our practice? And I get the pleasure of working with Justin Schweitzer and Mitch Eibach, who are both rock star optometrists and helping run the clinic and help me make a lot of these decisions. And it's basically a patient whose IOP is well controlled on a prostaglandin, but they're not tolerating their drops, or they're not able to get their drops in, or they're potentially cost prohibitive. And so it's not, occasionally we'll do it for a patient that maybe is still progressing in the hopes that they get a better effect from the Durysta than they did from the topical medications. But mostly it's somebody who's doing well from an IOP lowering standpoint, but not from a compliance standpoint. And those are the patients that I pick.
Yeah, I completely agree. I mean, those are the indications. Sometimes it's just a feeling you have when you look at an eye and you think, this eye does not seem to be happy with what's being placed on it. George Spaeth once described, topical therapy as pickling the eye, because preservatives, pickle things. That's how you keep, things in a certain state. It's not a healthy state for the eye. I also just think about, how all patients can't possibly be perfectly compliant. And there's just some group of patients that's horribly compliant, and it's tough for us to know which ones they are. But when we encounter a scenario where we're suspicious that the patient's drops are not getting in more often than not, then guaranteed therapy is really something that I don't think we think about it enough. But this is a guarantee for a patient for a period of time, and life doesn't have that many of those.
All right, should we see the video?
Let's take a look at the video. And I love this setup.
Well, yeah, thank you. So this actually isn't me. You can tell because it goes so smoothly. But a couple of things to notice. One, this is done at the slit lamp typically. Some folks do it in the operating room in an ASC. Some people do it in like a laser suite where you lay down. This needle is a especially sharp, thin-walled needle that penetrates the cornea really nicely. The cornea is stiff, and it can be hard to get typical needles through the cornea. So this is well designed. And then you just see that ejection into the anterior chamber, and you saw that little pellet float down into the bottom of the AC, and that was textbook. Most of the time in our practice anyway, we don't put in an eyelid speculum, but we do prep the eye with betadine and a numbing drop, and essentially that's it. I'm hoping that you're kind of fast forwarding here to the place right where the little pellet gets ejected.
Well, I want to make one point first, which is that, your patient here has, I think, a 3-piece lens. Yep. And that there's been a YAG capsulotomy. I know this comes up a lot because people worry about in the label, it says, hey, should have, but this is excellent capsular support. And I see overlap between the optic and the capsule. And even though, there's a bit of an opening here, in some sense, it's almost a unicameral eye. We really do have a good support. We have an anterior chamber and a vitreous cavity that are separate. And so I think this was a good person to inject, even though they've had a YAG caps.
Yeah, and even if you didn't have that, this patient happens to be widely dilated. If you were worried about potential posterior migration, which we don't know if it would cause a problem anyway, but if you're worried about that, you could have the patient not dilated or even constricted, and it's more likely that it will stay in the AC.
And because the patient's dilated, I'm guessing whoever it was who did this made the decision to inject on a patient visit. And it's one of the things I like about Durysta is if they have, usually it's Medicare with commercial secondary, you can make the decision during the visit, you can inject, and in fact, it's still a reasonably timely visit. So to me, this never disrupted my clinic, even when I'm making like day of decisions.
Nate, I think it's such a good point because our job as doctors is to keep patients out of doctors' offices, out living their life. And, having people come in on another day for another test, for another procedure, none of us want to do that. So if we can find a way to just put on what would I want if I were a patient hat? Of course, you'd want to be seen the same day and have the injection the same day.
Absolutely.
And so here comes the injection. Boom.
Right to its home.
Yeah, right to its home. Go to your home.
After the injection, I don't worry too much if the corneal incision is leaking a little bit. We know it won't leak forever, or else we'd have a treatment for glaucoma there. And so, I've given the patient some tetracaine, some betadine, and then that's it. I'll just see them back after.
Yep. How quick do you want to see them back, Nate?
Same as many of the things we do, starting a prostaglandin analog. There's some people I see the next day, the next week, the next month, or in 4 months. And it all depends on the patient's scenario, severity of their disease, how high the pressure was. But for example, if I had a woman with normal tension glaucoma, initial treatment IOP was 16 millimeters of mercury on a prostaglandin analog with a pressure of 12, but getting blepharitis or meibomian gland dysfunction, I would inject Durysta and see that patient in 4 months.
Yeah.
I'm not worried about major pressure problems. I would tell the patient if there's any problem to please call or come in. But at the same time, if I had someone with a pressure 28 and a nerve that's more damaged, I might see that patient several weeks later, recognizing that Durysta really seems to have its best effect after about a month. In the first 2 weeks, I find the pressure could be up or down.
Yeah, and so you mentioned 4 months. That's what I think the end point was for the study for IOP lowering, but we've seen patients that have longer duration IOP. So how do you make the decision about when to start seeing them back and initiating new therapy if the IOP is still well controlled, say at 4 months? What do you do then?
So if they're still controlled at 4 months, I let it ride. And one of the things my experience has taught me is that this doesn't wear off immediately. In fact, it's almost remarkably predictable in a 1 millimeter per 1 to 2 month rate of ascending IOP. So what I often end up in is a scenario where now I'm 9 months. I injected them at a pressure of 24. They went down to 16 or 17, and now they're 19. And now I'm making a decision. And for me, that's, I look at the patient, I look at how happy they are, I look at how good their eyes look. And I'll often I'll let them go from 19 up to 21 and see them 3 or 4 months later. And the reason I do that is because I feel better about a guaranteed 19 or a guaranteed 20 with sustained therapy than I do about someone who might be 16 on a day when we definitely know they took their drops because they knew they were coming to the ophthalmologist. So it's about the quality. Yeah.
And maybe my last comment on this is that in the moment, it can be a frustration. I'm frustrated that we don't have repeated use labeling or insurance coverage typically on this. That doesn't mean we can't do it. It just means it likely won't get paid for. But when I zoom out and think about Durysta in drug delivery in the arc of innovation, no first to market technology is going to have all of the benefit of the tweaking that's happened over the last 20 years.
Yeah.
And so we can set the standard of care, we can follow the standard of care, but we need to be grateful that there is a drug delivery option.
Yeah.
And although there's some restrictions placed on us or obstacles placed in front of us, this is the advent of a new entire category of glaucoma care. And I'm grateful for the companies that have done the work and the innovation to break the ice and get us into drug delivery.
Absolutely. And to that point, you bring me right to my case. Now, let's just look at this eye and notice that there's already a Durysta in the inferior angle here, okay? And Durysta erodes slowly over a couple of years, and this patient is probably a year out. They had great pressure control. You can see it's a pseudofake, and now the pressure is coming back up. So I'm going to do a readministration. And interestingly, I found you do get paid for the second. You can get a prior auth to be sure. But again, the insurance companies, Medicare with commercial secondary, seem to not view this as an automatic no. So here we have the patient. Video is a little, there's some artifact here where it's a little jumpy, but coming into the eye, and I'm going behind the pupil in front of the IOL, dropping the Durysta into its other home, and coming right on out. And the reason that I've taken to doing sulcus injections in patients where I know they have an in-the-bag IOL is that it's away from the cornea. So I feel like I'm really getting rid of that corneal endothelial risk. And my results have been very good. Soon to be written up, but for me, indistinguishable from anterior chamber, except I sleep a little bit better at night, not having to think about the cornea. It is possible for an implant that's placed in the sulcus to come into the anterior chamber, although I would say most of the time it doesn't.
So do you do sulcus placement as your standard first?
Now I do in a pseudofake, yeah. Okay,
I'm still putting it in the AC. And your point about the endothelium, you know, I love that you don't have to think about the cornea, but I do, because I'm cornea and glaucoma and do a lot of endothelial transplant. But, you know, my mantra on that is that the endothelium can be replaced. The ganglion cells can't. And so, although we don't want anything that does, you know, cause the cornea to decompensate, with a straightforward, safe procedure, we can fix that. I did it on my own dad, and because he had Fuchs. And so anyway, the main point is you can't regenerate the nerve, you can regenerate the endothelium.
Yeah, and amazing. And maybe soon we'll have even better therapies for the endothelium. Yeah. I wanted to just show just a quick SLT video. And, you know, nothing really fancy about this video, but this is part of our treatment as well. Where are you at with SLT now as, you know, primary therapy?
Yeah, you know, I think that it should be the primary therapy is the take home point. However, every year when we do our symposium with a couple hundred referring optometrists in our region, we ask them, if it was your eye, what would you want first? 95% of the hands go up for SLT. When we ask the doctors on the surgeon and the optometrist in our clinic, 100% of the hands go up on SLT. Then you say, what percentage of your patients actually get SLT first? And it's like 15%. So there's a huge disconnect between what the doctors would want for themselves and what they think is right and what actually happens. Now, that has moved more in the direction of SLT as primary therapy. But to me, this is not a tough call. This is an easy call. SLT should usually be primary therapy.
Yeah. And there's some sort of false consensus that goes on where you think everybody else would want to use it later. And so you adhere to this norm that you've created. And I think just recognizing insurance companies pay for it as primary therapy. I have insurance companies in New York that don't want me to put a stent in until the patient's had SLT. That's creating some headaches for us because we want to take the cataract out whenever that patient is ready, not after they've had a laser. But, the point is made that when I get referred a patient from one of my optometrists for SLT, I can't think of a time where I've said, no, this is an inappropriate therapy. We're going to do drops instead, because it's now just been proven to be a better therapy, fewer patients going on to get surgery and fewer patients progressing, fewer rapid progressors with laser compared to latanoprost, despite seemingly equivalent IOPs.
Nate, you probably do as much SLT as anybody in the country. Let me ask you some rapid fire questions that
Sure.
I think help optometrists. Number one, what is your success rate with SLT on a virgin eye?
Probably 85%, 90%, very, very high. Big mistake is using SLT too late.
Define that success. How much IOP lowering?
9 millimeters in the light study. I would say, because I'm not always treating people with a 25, that I may see pressure reductions of 6-7 millimeters, but getting people to their target where that post-op visit at 1 month or 6 weeks is a fist bump or a congratulations and a positive event.
Okay, great. How often do you repeat it and when?
So the light study suggested that if you do have a non-responder, you can go right ahead after 3 months and retreat. I still like to see someone get control for 2 years, and then I will repeat. To be clear, I'm not treating that many patients 3 times in their life, and it's because the 2 treatments tend to last people 10 years in my experience. So, there's a lot of time under those treatments.
And so just, optometrist having a conversation with their patient says, you have a blank chance of blank percent IOP lowering for blank years.
Yeah.
Fill in those blanks.
Okay. So you have at least a 75% chance that this therapy alone will control your glaucoma for the next 3 years. By the way, that's better than latanoprost, because if you look at market research, at least 40% of patients are on more than one eye drop. So you can conclude, and of course, in the light study, we saw a lot of people needing adjuvant therapy with latanoprost. So it's simply a better therapy than latanoprost, period, full stop.
Okay, post-op care, what do I need to pay attention to as a referring optometrist?
Yep, it's a very safe procedure. I think the real question is whether you're going to treat the patient with an NSAID or whether you're going to try to get away without anything. Patients will get some photophobia in maybe 10 to 15% of cases. I tend to treat people who have pigment or, seem to be a little bit more prone to inflammation with an NSAID, but the majority of people I try to get away with nothing. And really, other than that iritis, which they can get for a few days after the laser, and pigment spikes, pressure spikes, which can happen in people with very pigmented angles, it's a very safe procedure.
Lastly, what glaucoma medicine should I add first if they don't get the IOP lowering we're hoping for?
Yeah, the answer is probably still whatever the most efficacious therapy is, and that would usually be a prostaglandin analog. We think Rho kinase inhibitors would still be additive because they're decreasing episcleral venous pressure. And we know that it's kind of backward reasoning, but you'll get better pressure reduction with SLT if you do it for someone who's on timolol than on a PGA. But in my opinion, that's just because the patient who's on timolol was partially treated and the patient on the PGA was more comprehensively treated. Well, we've got some MIGs. And so do you think there's an algorithm for which MIGs when? It gets talked about a lot because we have so many options and people want to clarify things, but you give me the real world here.
Yeah, there's not an algorithm. I think that it goes like this. There is, just like humanity, there's much more that binds us similarly than differentiates us. Okay. Yeah. So first thing that I'd like to believe is that, hey, MIGs, and MIGS devices and companies, they're all on the same side, trying to lower IOP safely. So if there is some differentiation, it's probably in general that you trade a little bit of safety. And when I mean safety, I don't mean like bad safety. I mean a high FEMA for a week for a little bit more efficacy. And, as far as the algorithm goes, I don't believe there is one. In general, if I'm going into somebody's eye only for the glaucoma procedure, not combined with cataract, I'm going to do whatever I think is most aggressive for that surgical procedure to safely lower IOP. So I'm usually combining procedures. And by that, I generally mean adding ECP to whatever goniotomy type procedure I'm doing. If I'm going into a patient that has cataract surgery and they just happen to have glaucoma, then I'm usually using a stenting procedure, but there's variation within those. So no algorithm, the similarities dominate the differences. And I think that surgeon comfort and approach is what's most important. I also believe that it's important to have high quality data. And I do love innovation, but I do think there's a responsibility that comes along with that innovation to provide data to help surgeons and optometrists make good recommendations to their patients.
I agree completely with everything that you said. And I think that there are some cases where you can just say, gosh, I feel like these therapies might be the same, but this one, we have the Hydrus in front of us. They have 5-year data. They showed that they can, compared to cataract surgery alone, slow the rate of visual field progression. I almost feel like they deserve some sort of reward just for generating that type of data. Even if you have a suspicion that other procedures, stents, non-stents, things might do something similar.
I agree, Nate. I mean, we should reward folks that do the hard work of generating the data and raising the bar for all of us and advancing the science. And that's all, of course, secondary to doing what you believe is the right thing for the patient in front of you. And then the last comment I would make is sometimes there's a surgical approach thing where there's a heavy brow or some PAS in one area of the angle that may, indicate a different surgical approach. That's the exception, not the rule. But yeah, I completely agree with you. Let's reward high quality data.
Yep. And to that point, I mean, we're calling out Hydrus here, but many of the companies in the MIG space are heavily committed to this and are doing many different studies that are designed to help us. So I don't mean to imply when I say that there isn't high quality data. In fact, you see companies getting a label. Sight Science was able to get their labels sort of enhanced because they produced data to the FDA, and that's helped them because now they have indications, which can help with insurance payments, and then it ultimately helps the doctors and the company and the patients. So
yeah, and I would also say it's not just on the companies to provide data; it's on the docs too. And so those of us that are doing a lot of these try to contribute to the literature to help our colleagues make better decisions, and I'm sure grateful when other folks contribute to the literature to help me make better decisions.
And would you say, I would say from my experience, when I'm, again, sort of working with a optometrist in my clinic and they have a suggestion for what type of procedure, how does that usually go for you? Do you find that you're pushing in the different direction or usually going along with, what's been suggested?
I love it. And that's true of not just glaucoma procedures, but it's true of IOLs selection. Here's how I view it. We've got a highly co-managed practice. And I view it like I'm a consultant for the optometrist that's out there on the front lines doing the hard work trying to decide things. But what they have, and another thing they have as a big advantage, is they've got a 20-year relationship with this patient. They know this patient much more deeply than I ever will in our 20-minute consultation. And so I heavily weigh that. And then if a lot of times they're just right and we agree. And if I'm seeing it a little differently, we'll pick up the phone and we'll have a conversation and say, hey, I'm thinking this. I saw you were thinking this. Let's get to a consensus. And we always do. So I love that.
Yep. Totally agree. Okay, let's look at a Hydrus here. So it's a beautiful view of the angle.
Yeah. And so, one of the things that's really nice about a hydrus is that it's satisfying. You see it go into that trabecular or into that canal schlemm. It's covering 6 millimeters. It's putting the trabecular meshwork on stretch. You've also got that peripheral inlet, and slide it in. It's seated, and you know that you're accessing a number of collector channels there. So it's a beautiful procedure. This is us doing this. I've made it look harder than that too. It doesn't always go in that smoothly. And I think that that's maybe one of the challenges of the hydrus. But like you said, Nate, they're the only one that I'm aware of that has shown an improvement in visual field at the 5-year time point. The IOP lowering is good, and it's a great procedure and a great tool to have in the toolkit.
Absolutely. And we've got a lot of different stuff here. So we have some iStent inject, the W, here being put in.
I was just going to say, iStent, I think that most people are very familiar with, right? It created the MIGS category.
Yeah.
A lot of good peer-reviewed data out there. The iStent inject is the second generation. You put in 2 of them. The W is a wider flange. That doesn't really mean much to anyone except for surgically. It's nicer that it won't penetrate through the trabecular meshwork. It kind of stops because there's a wider flange on that rivet. You can see the images over there. Smallest device implanted into human beings. This is this is our most common MIGS that we use in our practice. We published a lot on it. And it's tiny and it's safe and it lowers IOP.
And we are thinking that we're going to get 3 of these for standalone use at some point in the future. I imagine you're involved in some of these studies, and how do you think that's going to change what goes on in terms of our treatment?
Yeah, I think that you're right. So we're looking to do what's called iStent Infinite. iStent Infinite would be not an infinite number of stents, but an infinite number of pushing the buttons to put 3 stents in. And, basically I think about this, I was a physics major, so I'll geek out a bit, but it's creating parallel circuits. And so you've got more shots on goal to be close to a collector channel, but now you've got parallel circuits that can take that flow of aqueous out and lower the eye pressure better. The results that I'm aware of have been surprisingly impressive. I mean, we expected it to be a bit better, but it was surprisingly impressive. Now, what will probably dictate it is what the label says and what insurance companies cover, because if you could put in 3 in everybody as opposed to just 2, why wouldn't you? I don't know that will be a practical solution insurance-wise. I hope that it is, because I just want the freedom to do what I think is best for patients, but we'll see. Certainly for standalone. In refractory glaucoma patients, that's the label that they're looking for.
Yeah. Yeah, it's fascinating. And the thing in my mind is it working better because you're getting 3 small pathways going, or is it working better because you just increased your chance of hitting the God shot and like drilling into the pipeline at the critical part and just getting the least amount of resistance in one area?
Speaking of which, our friend Ike talks a lot about identifying collector channels and putting a stent next to them. I've tried doing that. I can't do it. I can't see exactly where the aqueous veins are. I'm colorblind, so maybe I can blame it on that. But Nate, you're one of the best ophthalmic surgeons in the world. Not as good as Ike, but can you do that? Do you do that?
No, and I think at some point I did a Cahook dual blade, and I watched 6 collector channels all opened up, and I'd removed a huge strip of trabecular meshwork. And I was thinking, I mean, did I just target 6 collector channels? And I do think that KDB works very well. I think that's one of its, one of its pluses is it seems to have great efficacy for a TM procedure. You maybe get a little bit more bleeding. Not really a lot of data on that, but I think a number of surgeons have a sense that, when you really open comprehensively, and again, we're talking about single digit numbers of percentages between these devices, but that sort of got me to say, well, why target when you can just kind of comprehensively address these things? And
Yeah, right. If 3 is good, then is a whole strip even better?
Yep.
Yeah, and I think that, the continued generation of data will be helpful for that. And one of the things that I would just, caution anybody looking at the data too is, one, look at the source. A lot of times what happens is you say, hey, I trust Nate and I'll just listen to what he says. But I would really encourage you to look at the data for yourself, because we're all trained to understand what the data says and make our own conclusions, and then be influenced by the trusted experts in the field, but mostly look at the data ourselves. And that's why it's so important to do that. A couple of things on data. Glaucoma data that's masked is much more reliable, not because people are trying to cheat the system, just because it's natural to dial that Goldman down a little bit. So masked data is really important. Prospective data is important too. Retrospective data has some risks in it, but if it's a big study, I'm not too worried about that. But I do really appreciate when IOP lowering is masked. And then you have to pay attention to medications too, and you have to pay attention to baseline IOP for how much you're lowering the pressure.
Yep. And the trick with the meds, and I'll just start this video KDB here as we talk about it, but not everyone tapers. So when I look at retrospective studies, you have a lot of people who are probably on drops that didn't need to be on them.
Right. That's right.
And that's to anyone co-managing, pick a time, 1 month, 6 weeks, 3 months, where you really ask yourself the hard question is, have I tried to get this patient off at least 1, 2, however many drops they're on? Am I sure I'm not over-treating this MIGS cataract patient? Because if you don't very, advertently think of this, there's a chance you'll just sort of say, well, their pressure's 12. I'll keep them on their 3 drops, when in fact they might be 12 on nothing, they might be 12 on 1 drop. And you do have to kind of play around a little bit.
Very few things are more satisfying than taking a patient off glaucoma drops. You think about how much that improves their life, how much that improves their finances. That's one of the single best things we can do to improve our patients' quality of life. Over there, you just saw Cahook Dual Blade. Quick reminder, Cahook Dual Blade is kind of this wedge device that has a ramp on it with 2 blades on the sides that lifts, puts the trabecular meshwork on stretch, and then cuts it. There's a number of ways to skin this cat. We go from the outside in on this procedure with me and my very talented partner, Mike Greenwood. I love origin stories, and the origin story of this, our good friend Malik Cahook developed this, of course, and it was originally as a research tool to try and get clean trabecular meshwork samples. And so it was developed as a research tool, and then maybe it'll work good.
Yeah.
Excising the meshwork in adults and even kids and lower the IOP. And it's been a successful product in the marketplace with a lot of data to support it.
Yeah. And I froze it right on the scene where he kind of takes the meshwork out of the eye. I mean, that's one way to know that you've opened up some outflow. And then the eye access is something new that we're seeing, which is microgoniotomy. And, this is a Treffin. Mark Gallardo developed this with Glaukos, and this kind of just goes and almost takes like a little core biopsy of the trabecular meshwork. You rotate it around, and you can take several shots at goal here. Again, what's interesting about it is, whereas Cahook Dual Blade kind of grabs the whole TM, you can micropuncture the TM in different areas, so you're still kind of accessing different collector channel systems, but you're doing it through a smaller opening. I assume you've had some experience here?
Yeah, so I've done a few of these, and a couple of thoughts. One, going back to what I said before, the similarities outweigh differences, right? We're looking for iterations on what's the best way to do a goniotomy. And I love having additional tools in my toolkit, and this is something that's so new that there's not a lot of data out there, and I'd like to see that data. Because usually I'd be going inside the eye only for this, not necessarily combining it with cataract surgery, although some people are doing this plus a stent, plus cataract surgery. But I like having more tools in my toolkit, and I want us to generate data around it.
Agreed. And I'm sure that's happening as we speak. Omni procedure has been around for quite some time now. This is gets into the concept of canaloplasty, which we haven't talked about yet. But canaloplasty may be a way to access multiple collector channels, but without attacking the meshwork at different areas. So you're putting a microcatheter, in this case, into the canal, and you're breaking adhesions, you're breaking discontinuations in the canal of Schlemm, trying to make it one continuous area. You are having a plasty effect where, just like angioplasty, you enlarge the canal, just like angioplasty enlarges coronary vessels. And you can combine it with some level of either stenting or goniotomy. And in fact, with the Omni surgery done in its proper form, as you see here, you're performing what's called an ab interno trabeculotomy. And this one is being nicely done here. So you've not only kind of plastied everything, inflated the collector channels as well, and then you're unroofing the meshwork.
Yep. Again, there's data out there to support this. This is, I would say, of the MIGs, it's a little bit on the more aggressive spectrum, maybe a little bit higher risk of hyphema risk. And, one of the things that can happen is that advancing catheter can dive down into the suprachoroidal space. And so from a surgical standpoint, I wouldn't say it's challenging. I would say it is a bit more challenging. I guess I would say it is challenging. All these surgeries are challenging. We get good at them over time, but none of them are infallible. And from a surgical standpoint, if you're doing that and you see the patient curl their toes or groan a little bit, you're pretty sure that that catheter is advancing into a place that you don't want. Now that it may actually lower IOP a little bit more, but it certainly isn't our intent, and it can also cause some hyphema. But this is one of the procedures I use a lot. Along most of these I do a lot of, and I use it frequently in pseudophakics, and I almost always combine it with ECP when I do it.
Yep, I've done a lot of that as well, or with micropulse, which is one of the other things I will sometimes do in these standalone cases. And yep, and I'll say, I think it is nuanced. I think anyone who can do cataract surgery can do all these MIGs. So, but at the same time, the effort that it takes to learn is always paid off, because if you learn this first, then other procedures are going to be comfortable for you. I will just quickly show
my arms wildly because I'm waving my arms wildly because my light just went off. It's motion detected, but it won't turn on. So I don't, hopefully you can see me okay. I can't get it on.
I want to just hit one last one here. Apparently we could turn this into a 3-hour session, John. And just since we're talking about all the MIGs. This is Nate Radcliffe, and I'm excited to share my streamline. I say we can only listen to one Nate Radcliffe at a time, but here, this is a streamline, and you'll notice it just has so many themes of the other procedure we've been talking about. This is a microgoniotomy, microcanaloplasty instrument, but you push up against the canal. This little teeny microcatheter gets into the meshwork. It performs the microgoniotomy. You can kind of see those microgoniotomies opening up here. You get a little blood reflux. And then this is sort of the money shot here. I'm going to go into the canal at a different area, inject viscoelastic, and you'll see it clean out the canal and confirm the patency of that other microgoniotomy. This is from New World Medical. It's newer, but again, you get 5 or 8 shots at goal here. Just kind of another neat, variation. And I think different surgeons are going to gravitate towards different things. But this is another new one that's very neat in my mind.
Genius device, really new. Looking forward to seeing and generating data around it, and then seeing how it fits into our algorithm. But really, ingenious device.
So, John, I think if we're going to leave ourselves some time for discussion, that we're going to be wrapping it up. Any closing thoughts on the tour de force of glaucoma options that we just waded through here?
Just that I'm glad that we don't have to go from drops to trab or tube anymore. There's a lot of things between that we need. They're focused on improving our patients' quality of life and controlling their glaucoma, not just controlling their glaucoma. But the overarching thought that I have is that I love our profession. And when I say our profession, I mean the profession of eye care. I believe that more than any other time, we're on the same team, trying to do the same goal. And that's, I mean, ophthalmologists and optometrists, and focused on taking the care of the patients in our communities. Sure glad that you guys all joined us and eager to take some questions.
Couldn't agree more. Thank you, John.
Awesome. Those were some great words of wisdom from our speakers, John Berdahl and Nate Radcliffe, who I have with me now. Thank you so much for that great presentation. So there are a couple questions that just to round up some of those insights that you gave. One question came up in regards to Durysta. I know that John, you had mentioned in the talk that you usually talk about it lasting about 4 months. Do you have any patient experience where it's lasted a lot longer than that? And does that influence how you kind of pitch it to patients?
Yeah, we do have patients that have, had good IOP lowering out to a year. Is that because of the Durysta? Is, the changes in IOP fluctuations driving it? I happen to believe that it's probably related to the Durysta, and perhaps there's some trabecular meshwork remodeling going on, but I don't really change how I discuss it with patients too much. I'll say, we're happy. The plan is to get this for 4 months. If we can get more, that's a bonus for us. And so I just try to hit it right down the middle of the fairway. And I'm certainly not trying to talk anybody into it. What I'm trying to do is help people understand what options are going to treat their glaucoma the best, but not forget that the eyeball is connected to the rest of the body, and really what's going to make their life the best, whether that's their financial life, their habitual life, putting drops in how their eyes feel, and their glaucoma.
So what do you say? I know one of the things when I was trying to kind of grasp Durysta and also the longevity of it, and kind of getting on board with wanting to offer it to my patients, but still kind of saying, okay, if it's 4 months in the lifespan of a patient who has glaucoma chronically, what do you say to the other doctors who are kind of still grappling with that? What's your insight that you give them that helps you push them over the edge to say, okay, this is the reason why I give it to my patients, even though the longevity of it might be shortened?
Yeah. It's not, I get to live my life in a few different worlds: refractive cataract, cornea, and glaucoma. And each one has a different kind of feel, but there's tools you can draw on each one of them. And, from the premium IOL world, I'm not interested in selling a premium IOL to anybody. But I am very interested in every patient knowing their options and me understanding their options really well, so I can guide them to what is going to be best for their life. And so when I talk with doctors about new technologies, it's simply the same thing. I put them in the seat of the patient. If you saw an orthopedic surgeon, you would want to know what your options are. That is our obligation, to help patients understand their option. It's our obligation to have us understand those options, and it's our obligation to help them get there. So it's simply, here's how the procedure works, here's the data behind it, here's what the drug does, and you're going to get 4 months, and it may last a little bit longer. Now let's put that into your algorithm.
Nate, your thoughts on that?
Yeah, I mean, I certainly agree with all those points, John. I think it has to do a little bit with what pressure the eye is under when you make the decision to offer Durysta. So for example, a well-controlled glaucoma patient who just has a red eye is going to do very well. Same with laser and Durysta, because their pressure is a tolerability problem. Their pressure is easy to control. You're fixing a problem. Those are the people I find last a year and a half, because they just didn't need that much to get under control, and Durysta can perform there. Someone with a high pressure and you think Durysta is going to do something different than their topical agent that they're tolerating fine, that's where you're going to be 4 months and looking for the next solution. So I do think kind of understanding what you're up against and using Durysta for tolerability problems and compliance problems gives you that longer runway, because you're not fighting like the worst pressure battle of all time in those patients.
Mm-hmm, mm-hmm. Yeah. I had a doctor who talked about Durysta, and put it into the perspective, if glaucoma is like you being in the desert and you're in this battle of you're just uncomfortable and hot and just tired and done with it, and you're going and someone all of a sudden just gives you a drink of water, would you take it even if that relief is only for 4 months, or would you say, no, it's the battle, it's long, I'm just gonna go, so it's relief, even if it's for a short period of time. It makes a huge difference in the person's quality of life. So why wouldn't you consider offering it? And that perspective really changed my opinion about, considering it and the benefits like you're also mentioning.
It's a great analogy, and it's consistent with the experience I've had. Patients have really liked the break for a little while to re-energize themselves and their eye.
Exactly. One other question about SLT as a first-line treatment. Now, I know that more and more doctors are getting on board. It is considered first-line treatment for glaucoma. In the setting of the patients, though, or do you feel like the patients are always on board with this? And are there any certain ways that you kind of present it to the patient to make it easier for them to say yes and move forward with the recommendation?
It's interesting. I think that the doctors are all on board. We all believe that it's what we would want for our first eye. Nate, correct me if I'm wrong, but I think I saw an article for you saying that the UK recently said it is first-line therapy.
Yep.
It's so the UK national, tell us about that.
Yeah, so the NICE recommendations from the UK now put SLT as a first-line therapy. They didn't go as far as to say it has to be done before drops, but they certainly said the doctor can make the choice. One of the things that Tom Samuelson and I have been talking about a lot recently is there's a big difference between saying you can have laser or drops and saying laser's better than drops. It's been shown in a study, and 80% of eye doctors would choose laser for themselves. That's ODs and MDs. Because they want a recommendation, not just options. And I feel very comfortable recommending SLT as primary therapy. I think I feel less comfortable now. Like I suggest drops, and I feel like, you know what, Nate, this patient deserves SLT. It's a better therapy, and you have the data now. You can't play dumb,
Mm-hmm.
and it's no longer your theory, which it was 4 years ago. Now it's been proven. So I feel obligated to recommend it, not just offer it.
And I think that Nate highlights a really important point. Patients want us to tell them what we think is best. That's why they're there. And so I find that saying, if you were my mom, or if this was my eye, I would do this, is what I want from my doctor and what our patients want from us.
Mm-hmm. Yeah, I think that's awesome advice. One of the things I know that I got from Tom Bruner, the CEO of the Glaucoma Research Foundation, is just talking about the terminology, using the word light as opposed to laser. After a conversation with him and just talking about how he had mentioned the term light just sounds so much more inviting than the word laser, because someone have preconceptions of what a laser is and what it can do to the body. Once I started introducing the concept of light energy treatment as opposed to first saying laser, I've had a major shift in terms of how patients have responded to it as well, because it just seems much more gentle, which it is, as opposed to thinking about something that's cutting. You guys have given us some wonderful insight. It's been a great time talking to you guys, and I thank you so much for your excellent lecture and your words of wisdom that have obviously given a lot of thought for the people who are listening. So thank you so much for today.
Thank you, Connie.
Mm-hmm.
Thanks, Connie. Good to see you, Nate.